is pump work of hearts, echocardiography. The cardiac cycle. Cardiac cycle consists of a period of relaxation, called diastole, during which the heart fills with blood, followed by a period of contraction, called systole. In the normal heart, cardiac activity is repeated in a regular cycle manner, with a resting heart rate of 75 beats per minute. The duration of each cardiac cycle is 0.8 seconds. Blood, normally, flows continually from the great veins into the atria. About 80% of the blood flows directly through the atria into the ventricles, even before the atria contract. Then atrial contraction usually causes an additional 20% filling of the ventricles. Therefore, the atria function as primer pumps that increase the ventricular pumping effectiveness as much as 20%. However, the heart can continue to operate under most conditions even without this extra 20% effectiveness, because it normally has a capability of pumping 300 to 400% more blood than is required by the resting body. Therefore, when the atria fail to function, the difference is unlikely to be noticed unless a person exercises. Then acute sign to heart failure occasionally develop, especially shortness of breath. During ventricular systole, large amount of blood accumulate in the right and left atria because of the closed AV valves. Therefore, as soon as systole is over and the ventricular pressures fall again to the lower diastolic values, the moderately increased pressure that have developed in the atria during ventricular systole immediately push the AV valves open and allow blood to flow rapidly into the ventricles. This period is called the period of rapid filling of the ventricle. The period of rapid filling lasts for about the first third of diastole. During the middle third of diastole, only a small amount of blood normally flows into the ventricles. This is blood that continues to empty into the atria from the veins and passes through the atria directly into the ventricles. During the last third of diastole, the atria contract and give an additional thrust to the inflow of blood into the ventricles. This mechanism accounts for about 20% of the filling of the ventricles during each heart cycle. Outflow of blood from the ventricle during systole periods of isovolumetric contraction. Immediately after ventricular contraction begins, the ventricular pressure rises abruptly, causing two AV valves to close. Then an additional 0.02 to 0.03 seconds is required for the ventricles to build up sufficient pressure to push the semilunar, these aortic and pulmonary valves, open against the pressures in the aorta and pulmonary artery. Therefore, during this period, contraction is occurring in the ventricles, but no uptime occurs. This period is called the period of isovolumic or isometric contraction, meaning that cardiac muscle tension is increasing but little or no shortening of the muscle fibers is occurring. Period of ejection, when the left ventricular pressure rises slightly, about 80 millimeters of mercury, and the right ventricular pressure rises slightly above 8 millimeters of mercury. The ventricular pressures push the semilunar valves open. Immediately, blood begins to pour out of the ventricles. Approximately 60% of the blood in the ventricles at the end of diastole is ejected during systole. About 70% of this portion flows out during the first third of the ejection period, with the remaining 30% obtained during the next two thirds. Therefore, the first third is called the period of rapid ejection, and the last two thirds are called the period of slow ejection. Period of isovolumetric relaxation. At the end of systole, ventricular relaxation begins suddenly, allowing both the right and left intraventricular pressures to decrease rapidly. The elevated pressures in the distended large arteries that have just been filled with blood from the contracted ventricles immediately push blood back toward the ventricles, which snaps the aortic and pulmonary valves closed. For another 0.03 to 0.06 seconds, the ventricular muscles continues to relax, even though the ventricular volume does not change, giving rise to the period of isovolumetric or isometric relaxation. During this period, the intraventricular pressures rapidly decrease back to their low diastolic levels. Then the AV valves open to begin a new cycle of ventricular pumping, and diastolic volume, and systolic volume, and stroke volume output. The cardiac cycle consists of atrial systole, ventricular systole, diastole of the whole heart. Atrial and ventricular systole don't occur at the same time, but their diastoles occur at the same time during the diastole of the whole heart. During diastole, normal filling of the ventricles increase the volume of each ventricle to about 110 to 120 milliliters. This volume is called the end diastolic volume. Then, as the ventricles empty during systole, the volume decreases about 70 milliliters, which is called the stroke volume output. The remaining volume of each ventricle, about 40 to 50 milliliters, is called the end systolic volume. The fraction of the end diastolic volume that is ejected is called the ejection fraction, usually equal to about 0.6 or 60%. When the heart contracts strongly, the end systolic volume may decrease to as little as 10 to 20 milliliters. Conversely, when large amounts of blood flow into the ventricles during diastole, the ventricular and diastolic volume can become to greater than 150 to 180 milliliters in the healthy heart. By both increasing the end diastolic volume and decreasing the end systolic volume, the stroke volume output can be increased to more than double that which is normal. On slide you can see structure of cardiac cycle and different level for atrial systole, ventricular systole and diastole. Remember, ventricular systole consists of isometric contraction phase, repeat ejection phase and slow ejection phase. Diastole of the whole heart consists of protodiastole periods, isometric relaxation phase, repeat filling phase and slow filling phase. Atrial systole, the end of diastole. Contraction of blood propels some additional blood into the ventricle, but 70% of the blood filling passively during atrial systole. Contraction of atria produce narrowing pulmonary vein and prevent backflow, but however some blood will regurgitate into the vein. Prior to atrial systole, blood has been flowing passively from the atrium into the ventricle through the open AV valve. During atrial systole, the atrium contracts and tops of the volume in the ventricles with only a small amount of blood. Atrial contraction is complete and in ventricle begins move blood. In the atrial pressure curve of figure, three minor pressure elevations, called the A, C, and V atrial pressure waves, are shown. The A wave is caused by atrial contraction. Ordinarily, the right atrial pressure increases from 4 to 6 mm of mercury done in atrial contraction, and the left atrial pressure increase about 7 to 8 mm of mercury. The C wave occurs when the ventricles begin to contract. It's caused partly by slight backflow to blood into the atria at the onset of ventricular contraction, but mainly by building of the AV valves backward towards the atria because of increasing pressure in the ventricles. The V wave occurs towards the end of ventricular contraction. It results from slow flow of blood into the atria from the vein while the AV valves are closed during ventricular contraction. Then, when ventricular contraction is over, the AV valves open, allowing the stored atrial blood to flow rapidly into the ventricles and causing the V wave to disappear. An impulse arising from the SA node results in depolarization and contraction of the atria, and the right atrium contracts slightly before the left atrium. This information you can see on electrocardiogram. P wave is due to this atrial depolarization. The PR segments is electrically quiet as the depolarization proceeds to AV nodes. This brief pause before contraction allows the ventricles to fill completely with blood. Isovolumetric contraction, the beginning of systole. The atrioventricular AV valves close at the beginning of this phase. Mechanically, ventricular systole is defined as the interval between the closing of the AV valves and the opening of the semilunar valve, aortic and pulmonary valves. Pressures and volumes during isovolumetric contraction. The AV valves close when the pressure in the ventricles exceeds the pressure in the atria, red and yellow color curve. If the ventricles contract isovolumetrically, their volume does not change, white color shown. The pressure inside increases, approaching the pressure in the aorta and pulmonary arteries. Green line shows this condition. On electrocardiograms, the electrical impulse during isovolumetric contraction propagates from the AV nodes through the His bundle and Purkinje system to allow the ventricles to contract from the apex of the heart towards the base. The QRS complex is due to ventricular depolarization, and it marks the beginning of ventricular systole. It's so large that it masks the underlying atrial repolarization signal the ventricles to fill completely with blood. Periodic ejection, repeat ejection. Semilunar aortic and pulmonary valves open at beginning of this phase. Period of ejection, when the left ventricular pressure rises slightly about 80 millimeters of mercury, and the right ventricular pressure rises slightly about 8 millimeters of mercury. The ventricular pressures push the semilunar valves open. Immediately, blood begins to pour out of the ventricles. Approximately 60% of the blood is ventricular at the end of diastole ejected during systole. About 70% of this portion flows out during the first TET of the ejection period, with the remaining 30% obtained during the next two TETs. Therefore, the first TET is called the period of repeat ejection, and the last two TET called the period of slow ejection. On graphic, you can see difference wave. C wave on atrial pressure is not normally dissembled in the jugular venous pulse. Right ventricular contraction pushes the tricuspid valve into the atrium. This marks the end of ventricular systole mechanically. On electrocardiogram, you can see baseline no deflections during repeat ejection. Reduced ejection, the end of systole. At the end of this phase, the semilunar valves with aortic and pulmonary valves is closed. Change pressure and volumes during this phase. You can see on this graph. After the peak in ventricular and arterial pressures, this you can see red and green line, blood flow out of the ventricle decreases and ventricular volume decreases more slowly. This shows white colors. Line. When the pressure in the ventricles falls below the pressure in the arteries, blood in the arterioles begins to flow back toward the ventricles and cause the semilunar valves to close. This marks the end of ventricular systole mechanically. On electrocardiogram, you can see T wave. The T waves is due to the ventricular repolarization. The end of the T wave marks the end of ventricular systole electrically. Isovolumetric relaxation, the beginning of diastole. At the end of systole, ventricular relaxation begins suddenly, allowing both the right and left intraventricular pressure to decrease rapidly. The elevated pressure in the distended large arteries that have just been filled with blood from the contracted ventricles immediately push blood back towards the ventricles, which snaps the aortic and pulmonary valves closed. For another 0.03 to 0.06 seconds, the ventricular muscles continues to relax. Even though the ventricular volume does not change, giving rise to the period of isovolumetric or isometric relaxation. During this period, the intraventricular pressures rapidly decrease back to the low diastolic levels. Then the AV valves open to begin a new cycle of ventricular pumping. Condition pressure and volumes during isovolumetric relaxation. Throughout this and the previous two phases, the atrium in diastole has been filling with blood on top to the closed AV valve, causing atrial pressure to rise gradually. Yellow line shows this condition. The V wave is due to the back flow to blood after this closed AV valve. Is the second discernible wave of the jugular venous pulse. The pressure in the ventricles, red color show, continues to drop. Ventricular volume show white color line. Is it a minimum and ready to be filled again with blood? Electrically, isovolumetric relaxation show like baseline, no deflection. Repeat ventricular filling. Once the AV valves open, blood that has accumulated in the atria flows rapidly into the ventricles. Change pressure and volumes during repeat ventricular filling. Ventricular volume increases rapidly as blood flows from the atria into the ventricles. White color lines show this condition. And electrically, on ECG, you can see baseline without deflection during a repeat ventricular filling. Reduced ventricular filling, diastasis. Rest of blood that has accumulated in the atria flows slowly into the ventricles. Is mechanical part of the heart. Pressure and volumes during reduced ventricular filling. Ventricular volume increase more slowly now. These ventricles continue to fill with blood until they are nearly full. White line shows this condition. Electrically, reduced ventricular filling. On ECG, you can see baseline, no deflection. On cardiac cycle, have influenced different type volume of the heart and preload and afterload. Normal volume of blood in ventricles after atrial contraction 110 to 120 milliliters in each ventricles. This end-diastolic volume. Contraction ejects near 70 milliliters. This stroke volume. Thus 40 to 50 milliliters remain in each ventricles. This end-diastolic volume. And fraction eject is near 60%. This ejection fraction. Preload. Tension of muscles when it begins to contract during end-diastolic pressure. For cardiac contractions, the preload is usually considered to be the end-diastolic pressure when the ventricle has become filled. In ascending the contractile properties of muscles, it's important to specify the degree of tension on the muscles when it begins to contract, which is called the preload. And to specify the load against which the muscles exert its contractile force, which is called the afterload. For cardiac contraction, the preload is usually considered to be the end-diastolic pressure when the ventricle has become filled. The afterload on the ventricle is the pressure in the aorta leading from the ventricles. Sometimes its afterload is loosely considered to be the resistance in the circulation reserve, then the pressure. The importance of the concept of preload and afterload is that is many abnormal functional states in the heart of circulation. The pressure during filling of the ventricles, this preload, the arterial pressure against which the ventricle must contract, this afterload, or both as alternate from normal to severe degree. During diastole, normal filling of the ventricles increase the volume of each ventricle to about 110 to 120 milliliters. This volume is called the end-diastolic volume. Then, as the ventricles empty during systole, the volume decreases about 70 milliliters, which is called the stroke volume output. The remaining volume in each ventricle is about from 40 to 50 milliliters, is called the end systolic volume. The fraction of the end diastolic volume that is ejected is called the ejection fraction, usually equal to about 60%. When the heart contracts strongly, the end systolic volume may decrease to as little as 10 to 20 milliliters. Conversely, when large amounts of blood flow into the ventricles during diastole, the ventricular end diastolic volume can become as great as 150-180 milliliters in the healthy heart. By both increasing the end diastolic volume and decreasing the end systolic volume, the stroke volume output can be increased to more than double that which is normal. Cardiac output is stroke volume equal the volume of blood pumped by either the right or left ventricle during one ventricular contraction. Formula for check stroke volume equal end diastolic volume minus end systolic volume, and normal range equal near 75, maybe 70 milliliters. Cardiac output equal stroke volume times 2 heartbeat. For frequency 75 beats per minute, cardiac output equal 5.25 liter per minute. Valve, these valvular factors about mitral and tricuspidal valves movements. Next, information about auscultatory area for fast heart sound. Site of hearing is the best head at the mitral area in fifth left intercostal space, about 1 centimeter from the middle line, medial-clavicular line. Yellow points show this position. Tricuspid area, lower part of the sternum at the sixth right sternocostal junction. This position for auscultation tricuspid valve. Characters of fast heart sound. Soft and low pitched. Its duration is about 0.15 seconds. Its head has a word lab by the stethoscope. Information about second heart sound. It occurs at the onset of ventricular diastole isometric relaxation phase of the cardiac cycle. Causes: sudden closure of the semilunar valves in aorta and pulmonary arteries, and the vibration that follow in the cusps. This information about valvular factors. Vibration in the walls of the aorta and pulmonary artery due to vibration in the aortic and pulmonary valves. This information about vascular factors like component second heart sound. All information you can see on pictures. This you can see location to valves, aorta valves, aortic valves, and pulmonary valve, semilunar valve. Auscultatory area for second heart sound, site of hearing is best heard at aortic area, the second right sternocostal junction, and pulmonary area, this left intercostal space near the sternum. To position for check second heart sound. On picture you can see more position these Airbits points for check pulmonary valves. Characters of second heart sound: sharp and higher pitched. Its duration is about 0.12 seconds. Is heard as a spoken word dub by the stethoscope. Significance: it indicates the end of ventricular systole and the start of ventricular diastole. It gives an idea about the condition of the semilunar valve. Its intensity is directly proportional with the arterial blood pressure. The duration between the first and second heart sound represents clinically the time of ventricular systole, as that between the second and first heart sound as the time of ventricular diastole. Third heart sound. It occurs during ventricular diastole, during maximum rapid filling phase of ventricular diastole. So it comes after the second heart sound. Causes: vibration of the relaxed ventricular walls due to rush of blood from the atria into the ventricles during rapid ventricular filling. Characters: soft and low pitched. Its duration is about 0.1 seconds. It's usually inaudible. It can be sometimes heard in children or persons with very thin chest wall. Significance: it indicates opening of the AV valves during ventricular diastole and rapid ventricular filling. Information about position difference component for third heart sounds you can see on this place. This you can see mitral valve condition during relaxation, and tricuspid valve and condition left ventricles. Auscultatory area. The two left ventricular diastolic feeling sounds for S3 and S4 for third and fourth heart sound are sometimes heard over the mitral area. The sound differ from first and second heart sound in that they are low frequency sounds produced by ventricular filling rather than associated with valve closure. Fourth heart sound. It occurs during the phase of atrial systoles, therefore is called atrial heart sound. Causes: vibration in the relaxed ventricular walls due to rush of blood from the atria into the ventricles under the effect of atrial contraction. Characters: its faint low-pitched sound. Its duration is about 0.5 seconds. It's normally inaudible, but can be recorded or detected by the phonocardiogram. And significance: it indicates atrial systole, late ventricular filling equal late ventricular diastole. The next slide demonstrated information about heart tone properties on electrophonograms. The first heart sound is due to the closing AV valves and associated blood turbulence. This slide shows information about comparing heart sound and mechanical information on phonocardiogram. During repeat ejection, after first heart sound, on phonocardiogram registered baseline. Next slide. During reduced ejection on phonocardiograms, heart sound is absent. During isovolumetric relaxation, on scheme you can see second heart sound. The second heart sound occurs when the semilunar valve, this aortic and pulmonary valves, is closed. Second heart sound is normally split because the aortic valve closes slightly earlier than the pulmonary valve. Repeat ventricular filling. A third heart sound is usually abnormal and that used to repeat passive ventricular filling. It occurs in the dilated congestive heart failure, severe hypertension, myocardial infarction, or mitral incompletence. during reduced ventricular filling. On phonocardiograms recorded baseline. This line show absence, difference, heart sound. During atrial systoles, on phonocardiograms recorded a forced heart sound is abnormal and is associated with the end of atrial emptying after atrial contraction. It occurs with a hypertrophic congestive heart failure, massive pulmonary embolism, tricuspid incompletence, or cor pulmonale. Murmurs. Cardiac murmurs are abnormal heart sound in the form of noise resulting from turbulent blood flow. Murmurs may be systole murmurs, they occur during systole, diastolic murmurs, if they occur during diastole. Causes. The main factors causing cardiac murmurs include stenosis, this narrowing of heart valves, incompletence of heart valves, and increase of blood flow or decrease of blood viscosity, as in anemia example. Next part of our lectures about echocardiography. During echocardiography, use special sonography valves. And this information about ultrasound valves. The technology of sonar or echosonography was originally developed during Second World War to detect submarines. The first echocardiograph was in the early 1950. A Swedish physics borrowed a sonar device from a local shipyard, modified, and recorded echoes from his own heart. Ultrasound test are non-invasive tests which use ultrasound or high-frequency sound wave to create graphic image of the heart's structures, pumping action, and direction of blood flow. Next, information about ultrasound studies. Echocardiogram, transthoracic echo, transducer directly on the chest wall, transesophageal echo, probe placed into the esophagus and stomach, and stress echocardiography, this transthoracic echo at rest and post-stress or exercise. Information about echocardiography. Echocardiography is method of investigation of structures and mechanical functioning of the heart, which is based on registration of reflected ultrasonic signals. During an echocardiogram test, ultrasound, this high-frequency sound waves, that some from a hand held when placed on the chest is used to provide pictures of the heart's valves and chambers and help the sonographer evaluate the pumping action of the heart. During echocardiography, cardiac area used for identification of structures of the heart, its normal and abnormal condition, allows for assessment for the motion and function of the heart and its various structures, follows blood flow through the heart and measures velocity of the blood flow, serves as a complement other diagnostic tests. Three interrelated processes utilized during the echocardiography: M regime, D regime, and Doppler continuous wave, pulses, waves, and color flow. On pictures you can see echocardiograph device for investigation heart work. M mode uses a single static beam and appears as horizontal lines with superficial structure at the top and deep structure at the bottom. One-dimensional echocardiography, the main distinguishing feature of scanning in M mode is the higher temporal resolution and the ability of visualize the small features of the structures of the heart in motion. At present, the study in M mode has remained a significant addition to the main two-dimensional echocardiogram. Thus, on echocardiogram, in the M mode, the vertical axis on the screen of the echocardiograph displays distance from structure of heart to the guard, and on the horizontal axis, time is displayed. On picture you can see first distance from structures and second heart time. The ultrasound focus into a narrow beam that passes through the structure of the heart. On picture you can see different structure of the heart. This you can see wall of the heart. This you can see condition of chamber. This information about ventricles. This information about septum. And this information about atrium. The image of these structures deployed on the plane during the movement turns out. The echocardiograms will have the form of a series of curves, each point of which at a certain point in time reflects the position of the heart structure at the same time. There are four main positions of echolocation. In the first position, the ultrasound beam passes through the anterior chest wall, anterior heart wall, right ventricular cavity, interventricular septum, left ventricular cavity, where the mitral valve cords interest at the posterior wall of the left ventricle and tissue behind it. The left ventricular cavity is limited at the bottom by the endocardial surface of its posterior wall and at the top by the endocardial surface of the posterior wall and at the top by the endocardial surface of the interventricular septum. Difference position probe give difference condition of heart. You can check difference part of the heart. On slide, you can see example second position echolocation. This you can see difference part of the heart. This you can see wall of the heart, condition difference chambers. This you can see mitral valve and left ventricular during diastole and during systole. And this you can see condition septum. Determination on echocardiogram of left ventricle during M mode. And diastolic volume normal range equal in this formula 7 times to 2.4 plus end diastolic size and times to end diastolic size systoles n cube. Next, end systolic volume formula for check end systolic volume equals 7 times to 2.4 minus end systolic size and times to end systolic size in cube. Normally, in adults, end diastolic volumes is 108 to 140 milliliters and end systolic volume within 38 to 50 milliliters. Next, information about stroke volume of the left ventricles is calculatory. The formula stroke volume equal end diastolic volume minus end systolic volume. Normally, in adults, the stroke volume equals 70 to 90 milliliters. Next, information about minute volume flow is defined as the product of stroke volume and heart rate. Normally, in adults, minute volume flow equal from 4 to 6.5 liters per minute. Next, information about left ventricular systolic function. And you can see normal range for ejection fraction. Normal more than 55%, mild between 40 and 50%, moderate between 30 and 40%, moderate severe between 20 and 30%, and severe less 20%. D-mode echocardiography. Two-dimensional echocardiography is the main method of ultrasound diagnostic in cardiology. The sensor is placed on the anterior chest wall in the intercostal space near the left edge of the sternum or under the costal arc, or in the jugular fossa, as well as in the area of the apical shock. Two-dimensional pictures of the heart is produced as a result of sound waves going out of the transducer and bouncing of a structure and then returning back to the transducer. On picture you can see different condition: diastole with mitral valve open and systole with mitral valve closed during D mode investigation. In D echocardiography, ultrasonic sound radiated by probe which quickly move in boundaries line 90 degree. Investigation determined in TED spaces of long axis, of short axis, and 4-chamber of heart. Position electrode left parasternalis long axis show condition difference chambers and difference part of the heart. This you can see condition left ventricles and condition mitral valve, condition semilunar valve and aorta, and left atrium. Next slide show short axis view on left ventricles. These you can see chambers right and left ventricles, size of wall left and ventricles, and condition septum between right and left ventricles. Next slide show position probe with short axis view aortic valve. On scheme you can see condition semilunar aortic valves, volume of right atrium and left atrium, condition pulmonary valves, and tricuspid valve. This you can see thickness, wall difference, chambers of the heart. Next slide show apical 4-chamber view. These position electrodes you can see information about septum, about apex of heart, thickness wall of left ventricles, and condition papillary muscles. This you can see chambers, difference atrium, left and right atrium, and volumes these chambers. Next slide show condition apical 2-chamber view. This you can see thickness of left ventricles and condition apex of the heart. This you can see papillary muscles, condition mitral valve. This you can see condition left atriums and size and diameter aortic arc. Echo is often combined with Doppler ultrasound and colored Doppler to evaluate blood flow across the heart valves. Doppler mode evaluates the path of the blood flow, evaluates the blood flow velocity as it moves through the heart and its structures. There are three types Doppler investigation: pulsed waves, continuous wave, and color flow. Doppler can be viewed as continuous wave, continuous transmission of signals with second transducer available to receive the signals. Pulse Doppler, same probe transmits, waits and the receives, and color Doppler, maybe color flow, vectors, directions, given colors, usually blue if flow is away from transducers, and red if goes toward the transducer. This information about difference Doppler investigation. On pictures you can see pulsed wave Doppler. Measure velocity of blood as it moves through the heart. Helps to assess how heart muscles squeezes the systoles and relaxes diastole. Continuous wave Doppler measure blood flow velocity as it moves through the valves. Measure degree of valvular regurgitation, measuring the density, length and shape of the waveforms. Helps of quantity, how severely a valve is leaking. Next slide shows color flow Doppler. This method measures the velocity and direction of blood flow via color patterns. Color Doppler show on this place you can see open and close mitral valve. Different colors show different direction for movement of blood. During open mitral valves and during closed mitral valves. The technique allows the relation of cardiac chambers, size and motion of function, the thickness of the walls of the heart, abnormal object in the heart, tumors maybe, or masses, valvular structure, the size and shape, valvular function, thickness, stenosis or leakage, blood flow, this is hemodynamics, and other pathologies, fluids and pericardial effusion.
the real-time images taken from the same patient at low and optimal levels of dynamic range. The time gain compensation setting. The ultrasound beam is attenuated as it is conducted through tissue. If uncorrected, attenuation will produce a scan that darkens progressively with depth. This is compensated for by the TGC, time gain compensation, amplifier, which progressively boosts the signals from deeper interfaces. This setting operates across the whole image, and so it is only possible to set the best average TGC for each examination. In this TGC setting, one will get maximal uniform boost of signals across the whole depth of the image. In the next TGC setting, one will get a low uniform boost of signals across the whole depth of the image. The third TGC setting is optimal for the majority of the echocardiographic examinations. In this clip, we demonstrate in the real-time images the correlation between different TGC settings and final images. Now, on the divided screen, you can see the direct comparison of two real-time images taken from the same patient. Note that the superficial heart structures on the upper image are too bright, but on the lower image, the in-depth enhancement of all heart structures is balanced. The overall gain setting. The overall gain setting allows us to enhance the image uniformity. One frequently changes this setting during the course of the examination. In this clip, we demonstrate how the real-time ultrasound image changes when the overall gain setting decreases. Then increases. Finally, when the optimal level of the overall gain setting is established. Now, on the divided screen, you can see the direct comparison of two real-time images taken from the same patient, an over-enhanced image and an image with optimal level of the overall gain setting. Finally, the image with a very low level of overall gain, and then with an optimal level of the overall gain setting. Changing the focus on the image. One should set the focus on the image in such a way that all structures of interest fall in the focal zone. If the focus is not set correctly, one loses the image quality. In this clip, we demonstrate how the quality of the real-time ultrasound image will improve when one shifts the focus to include the structures in the focal zone that were at first left out of it. Now, on the divided screen, you can see the direct comparison of two real-time images taken from the same patient. On the upper image, the focus is not adjusted, and on the lower image, the focus is optimally set. The optimal level of compression. The compression setting can considerably impact the two-dimensional image quality. By turning the knob clockwise, heart structures must fill up most of the sector. The zoom function. Sometimes one needs to investigate small anatomic details, and the zoom function can help in this situation. In this clip, we provide an example of using the zoom function when assessing the aortic valve from the peristernal long and short axis views. The colorized control. One can use the colorized control in order to change the color of the two-dimensional image. The choice is yours, but sometimes this can help improve the image contrast. The side loop function. The ultrasound system software remembers a certain number of final frames. After one freezes the image, one can use the trackball to scroll slowly across these last frames. The side loop function is used very often in echocardiography. The optimal level of overall gain during a color Doppler examination. For color Doppler examinations, the B-mode image should be set up with relatively low overall gain so that the image is a little on the dark side as the software tends to allocate color to darker areas rather than to areas which contain echoes. Now, on the divided screen, one can see the direct comparison of two real-time color Doppler images of mitral and aortic valves taken from the same patient. In the upper image, the overall gain is set too high, but in the lower image, the level of overall gain is optimal for color Doppler examination. Color gain. The color gain is set to the optimal level. This can be identified by turning up the active gain until noise or color speckle is seen in the color box, and then backing off slightly on the overall color gain. Color box. The color box size should be optimal. Large color boxes take more processing power and time size for mitral valve investigation. Finally, we demonstrate the optimal color box size for simultaneous investigation of mitral and aortic valves. Color Doppler. Determining the direction of blood flow. A very good example for the illustration is the image of the aortic arch obtained from the suprasternal approach. To determine the direction of blood flow, one must look at the color scale that is situated on the right side of the screen. The color of the upper part of the scale will match the color of the blood flow that moves in the direction of the transducer. In turn, the color of the lower part of the scale will match the color of the blood flow that moves away from the transducer. By turning on the color invert function, one can change the color scale. In this particular example, after increasing the color scale limit, we also increase the pulse repetition frequency. As a result, the color mosaic or aliasing is removed. After activating the color invert function, the blood flowing towards the transducer will be blue and the blood flowing away from the transducer will be red. Color flow image of the normal aortic valve. Aliasing, adjusting the color scale. If one reveals the color mosaic or aliasing on the color flow image of the normal aortic valve, the velocity scale should be corrected to accommodate the range of normal velocities across this valve. Color flow image of the normal aortic valve. Aliasing, adjusting the color baseline. Another way to remove aliasing is to adjust the color baseline. In this way, one can provide a wider range of shifts on one side or the other. Thus, one increases the velocity limits in one direction, but decreases the limits in the opposite direction. Color flow image of the normal pulmonary trunk. Aliasing, adjusting the color scale. In this clip, we demonstrate another case of aliasing in the normal pulmonary trunk. The aliasing is removed by correcting the velocity scale to accommodate the range of normal velocities in the pulmonary trunk. Color flow image of the normal pulmonary trunk. Aliasing, adjusting the color baseline. By shifting the color baseline, one increases the velocity limits in the direction away from the transducer, but at the expense of the velocities in the opposite direction. Pulsed wave Doppler, determining the direction of blood flow. To determine the direction of blood flow, one must look at the velocity scale. If the Doppler waveform goes in the direction of the plus mark on the scale, in this case above the baseline, the blood flow is in the direction of the transducer. The spectral inversion function allows the operator to change the orientation of the display. Now the blood flow in the direction of the transducer is presented by the Doppler waveform below the baseline. Many operators prefer to display the blood flow in the direction of the transducer with the Doppler waveform above the baseline and the blood flow in the direction away from the transducer with the Doppler waveform below the baseline. Now one assesses the blood flow in the descending aorta. The blood flow away from the transducer is presented by the Doppler waveform below the baseline, the minus mark on the scale. The spectral inversion function is turned on. Then one returns to the standard setting. The blood flow away from the transducer is presented by the Doppler waveform below the baseline. Pulsed wave Doppler, the aliasing. If the pulse repetition frequency is too low for the Doppler shift frequencies from the blood flow, aliasing will occur. As a result, one sees the wraparound of the Doppler waveform. One way of removing the aliasing is to perform the corresponding shift of the baseline. Another approach to removing the aliasing is to correct the velocity scale by increasing the pulse repetition frequency. In this clip, we demonstrate yet one more example of eliminating the aliasing by using the apical approach in the pulsed Doppler assessment of the